Okay, I think we are ready to get started. Kara, do you mind pulling up the first slide for me, please? Awesome. Aloha, everyone. It is such a pleasure to see you all here today. This is the session, Building a Health Literate Community to Achieve Health Equity, Insights, Lessons Learned, and Next Steps. And we are here. Thank you, Kara. I'm having some technical difficulties and I'm here on my phone, but absolutely honored and thrilled to be with you all here today to really talk about some nuts and bolts and experiences and foundational work around our team that's been working to build a health literate community to achieve health equity in Franklin County, Ohio, and really ponder about insights, lessons learned, and next steps from our projects. And what we really look forward to is also, because we have 90 minutes to both share our thoughts and then to hear your thoughts at the end. And so we've saved a lot of time at the end for a robust discussion and really look forward to this. Next slide, please. So as we all know here, it is really critical to think about health literacy in the framework of achieving health equity. And the Healthy People 2030 framework really undergirded that with really specifying and stating the goal of achieving health and well-being requires eliminating health disparities, achieving health equity, and attaining health literacy. And adding health literacy is a fundamental, crucial part of really achieving health literacy, or achieving health equity and reaching our Healthy People 2030 goals at scale. Next slide, please. And really one of the things that I think has been really exciting to see in the last decade, really, as health literacy has really grown and flourished, and the Thriving Conference here is a good testament to, is really thinking how we build not only health literacy within the relationships we have, doctor-patient communication, and individual health and well-being, but really how we scale that up and think about building health literacy at a community level as well. Next slide, please. But what are the nuts and bolts tools that we do in this space, right? How do we build community health literacy? I don't think we have all the tools known to us at this time. And I don't think, we figured that out yet, right? Otherwise, we certainly would have had a different pandemic. And so really thinking about then what are the options and how are the strategies in which we can achieve that is something many of us, I think, on this call and in this conference and worldwide are working on together. And so we're really excited to talk about one strategy and one perspective around that. Next slide, please. So this panel specifically, we're going to talk about insights, lessons learned, and next steps from an Office of Minority Health funded project where the focus is on building community health literacy to achieve health equity, specifically through improving organizational health literacy capacity and networks in Franklin County, Ohio. Next slide, please. So this project is a really awesome collaboration among public health departments, healthcare organizations, and diverse community organizations in Ohio, as well as with our team at the University of Hawaii. And so that's been really fun for us as well. Next slide, please. So really what we'll think about, and I framed it already, but just to make it a little more explicit, is to think about, we all know in public health practice, healthcare, and community organizations that we have these shared goals to think about and build health literate communities. But practice implementation and measurement on this topic are still emerging. Next slide, please. And so the panelists today are really going to talk about our experience implementing and establishing a health literate community in Franklin County, Ohio, through this iterative quality improvement approach to organizational health literacy capacity building, and leveraging and learning from these emerging networking and social components also that we built into the evaluation plan to inform future practice. Next slide. So together, we'll talk about the pathways to build a sustainable organizational health literacy community through trainings that build such capacity across community organizations and network-focused engagement to ensure lasting relationships. Next slide, please. So I'm Titine Centel. I'm the interim dean and professor of public health at University of Hawaii at Manoa. And so first I'm going to set a little groundwork for the conversation that we're going to have with the rest of our amazing team members. Next slide, please. Then you're going to hear from the wonderful Heather Pennington, who is the Community Health Initiative Supervisor from Franklin County, Ohio, the project lead agency. And she's going to talk about the public health organization, or the public health perspective from how this lead organization has framed and achieved this, and give you kind of the landscaping of the whole project in full. Next slide, please. Then the also wonderful Dr. Marianne Abrams, the Quality Improvement Officer, Medical Director at Nationwide Children's, who has a long history of organizational health literacy, is going to share with you very specifically some more of the mechanisms and component parts of the organizational health literacy perspective, and how we're thinking about that and how we're working to achieve that from a quality improvement perspective. Next slide, please. And then finally, the also wonderful Kara Psyche from our University of Hawaii evaluation team is going to talk about how we've been evaluating this, both in terms of the nuts and bolts of what we've been counting and evaluating and what we've found so far 1 year in from this project, this 2-year project, and think about what we've learned, and then think about next steps. Next slide, please. And then, as I mentioned, we really are hopeful for a robust discussion. And so really look forward to your thoughts about how you're working to achieve community health literacy across the venues in which you serve and where you work, and thinking about then also what we can do collaboratively to understand together. And then, of course, any questions or considerations you have. And so our goal for this is for each panelist to go one by one. If you have a clearing for about 15 minutes. And then if you have a clarifying question, we will answer those. But we'll save, again, the sort of larger discussions until the end, given our goals to have this robust discussion with you all. Next slide, please. So again, as I mentioned, we want a meaty discussion, both with thoughts and considerations from your context, as well as thinking about these nuts and bolts, because I think this is really one of these exciting things. And of course, we're not the only Office of Minority Health funded activity in these community health literacy spaces. And so no, there's a lot of exciting activities going across communities across the United States. And just seeing this sort of idea of health literacy built at scale has been really exciting. And so really want to be able to share thoughts and considerations. Next slide, please. So I just have a few slides to kind of set us on our stage, and then I'll turn it over to Heather to tell you about this specific project. So next slide, please. So we all know personal health literacy, the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Next slide, please. But as a public health professional, and as many of us work in these spaces, you know, the individual specifically is, of course, embedded in context. And the social ecological model, I always find really grounding when I think about work and how to think about where we engage and where the levers are to make meaningful change, especially around health equity, but really in public health and well-being for our communities writ large. Next slide, please. So this consideration that the individual, of course, in thinking about how to build their health literacy and to engage them and to build on their strengths, right? To build on strengths that individuals have with each other can only be considered as nested within these contexts. So next slide. So how we work together with those around us, our families, our networks, our close relationships, our caregivers, those we care for, to make sure that they have the health literacy engagement and information that they need, and to understand things together and to work closely to do so. Next slide. So here's from a study just we recently did in Hawaii, just looking at individuals who others are searching for, and so that we engage collaboratively together with others to think about and build health literacy. Next slide. So then, of course, organizational health literacy, which has had tremendous innovations and engagement and ideas and research in recent years. And really thinking about that organizational health literacy perspective and how important it is to build, you know, not force, of course, individuals and their caregivers and loved ones into systems that make it hard for them to achieve their goals and understand information, but also that we really think about how organizations themselves can make it easy for people to understand the health information they need, get where they need to go, make decisions, et cetera, et cetera. Next slide, please. And so, of course, Healthy People 2030 really importantly added this organizational health literacy and put the onus and responsibility on organizations as well to make sure that we have, that they are working to achieve health literacy. And I think that's really exciting. And of course, what Marianne will talk a lot about today. Next slide, please. But I do think this principle is really exciting because not only does it have the potential to reduce inefficiencies and duplication while allowing for patient-focused goals of engaging, understanding, and supporting across all our goals, prevention, decision-making, and self-management. There's really hope this can do a lot of other things. We've seen how important they are in the COVID times, providing strong patient-provider relationships, strong conversations, including deepening trust and communication. And then, of course, there's the power shift, right? Moving and thinking about the organization towards these goals really thinks about how these organizations can change the power dynamic and stop these systems from disempowering our patients and their families, and really thinking about how we achieve health equity through systems that make people feel comfortable, empowered to get the information they need in a culturally and linguistic relevant way for them and their families. Next slide. So then, of course, the community aspect, right? How do we know what communities need? Who gets to speak those voices? How do we share and engage with community-focused organizations, with community members, and what that looks like? And that's been a really exciting part of this project as well that we'll hear a lot about, because the networks and the organizations served really represent key facets of the Franklin County community. Next slide, please. And so this is really, again, this very exciting piece of, we've talked about this for many years. This has always been undergirding our goals of health literacy in the decades I've been in health literacy. And just to really see these opportunities for how this is coming up into scale and into spaces, and with, deep funding behind it, has just been tremendously exciting. So these are quotes, from back in the day, but just thinking about now really how we're working to achieve health literacy at scale is very exciting. Next slide, please. And then, of course, how important this community health literacy perspective is, and the infodemic, and how we can think about stopping and improving and changing really the dynamics around us and the social norms around us for health information, and how important that is. Next slide, please. And then finally, how, of course, we build the society that we want to see in the world we want to see with health literacy at the center towards health equity. And so very exciting there. Next slide, please. And then to this, again, this ambitious goal, right? The Healthy People 2030 goals with really health disparities, achieving health equity, and attaining health literacy at the core of those goals. Next slide, please. So here we are again to talk about some nuts and bolts around what that looks like. And so just very excited to be here today with you all to facilitate and support that conversation. And again, for my wonderful colleagues to share their thoughts, which is about the time we are now. Next slide, please. And so this is the Advancing Health Literacy Framework and the ambitious goals, and you can see them here. Very exciting, and I know Heather is going to talk about them in detail, so I will not spend my time doing that, because I know you're very excited to hear from our colleagues. Next slide, please. But what I want to highlight is really thinking about those levels of the social ecological model, is really thinking about how organizations and communities come together as the way then we achieve health literacy goals across those other levels of the social ecological model. Next slide, please. And then we have the social network component and piece in the background. And so the idea is that there were many people already in Franklin County and working in health literacy and specifically with organizations towards those goals. And one of the things we're doing, and this is an example from another study, is just to visualize where we're going with these mechanisms, is to really think about then how we take these organizations that are working maybe in the space with deep experience and knowledge, next slide, please, and really link them together, right, to build a robust infrastructure and engagement with each other with meaningful trainings and opportunities. Next slide, please. To really keep growing. And then the idea is that that builds knowledge within those organizations, but also strong and sustainable networks over time. And so that's where we're headed. And then also you can see sort of with those robust networks, then also ancillary and growing opportunities for engagement with other organizations across different types of sectors. Next slide, please. And so then this is just the visualizing, we're in the middle of measuring and what this looks like in Franklin County, but just also that sort of cross-sector engagement and opportunities for robust infrastructure for networks that support health literacy across. So very exciting and really excited about that component of this work as well. Next slide, please. And so this is one of my favorite things so far of this project is in thinking of our goals and where we were headed, we were able to do focus groups with some of the people working here and really thinking about across the levels. And so this is one of the community health workers in one of the organizations working to build health literacy, talking about his own individual engagement and strength-based approach to this work. And so he says, you know, when he's out and about, he talks to people. He's not just working 9 to 5, as we know many community health workers do, but he's working across time and in his personal relationships when he's at the store, talking to others, really talking about wherever he meets them, what that looks like, how to build and think about the health information he wants to share for children and for the older generation as well, right? So really thinking of that like big societal perspective, engagement perspective as a goal undergirding, again, all this and why we do this work, right? Really thinking about communities and that this really helps multiplying, right? The impact goes multiplying. You go into the community and then it can reach others and others. And I just think that's really the goal of the project. And when he spontaneously was sharing his perspective on this work, it was just really thrilling and really gratifying for us. Next slide, please. So this view of health as a collective, I think, is really important and really undergirds, again, a lot of the work and goals we have together towards building community health literacy and then building community health literacy really in networks. And then I think that collective and that engagement really is not only important for thinking about how we're grounded in these ambitious goals and what that looks like and where we're headed, but also how we make that sustainable over time when our 2 years of funding ends and we think about what is next steps. Next slide, please. So that is all from me. Mahalo for your time and engagement, and I will turn it over to Heather to tell you specifically about this project and what it looks like and its nuts and bolts parts. Thank you.
Thank you, Tatine. And like Tatine, I also am having some technical difficulties, so Dr. Abrams is going to help me with my slides. So first and foremost, I just want to say that Dr. Centel talked about our wonderful team, and I want to mention that she is equally as wonderful to work with. And it's a pleasure to be here today and to have the opportunity to talk about this wonderful, impactful work we're doing here in Franklin County towards building a health literate community. And just the opportunity to work with this amazing team. And we are working as Advancing Health Literacy Franklin County. You could, next slide. Before we get started, I don't think that's my next slide.
Oh, I think, Marianne, are those your slides?
All right, well, as we're working through the slides, we can, it's okay, we can work with those. I just want to take a second to acknowledge that as Tatine mentioned, that this is the work we are doing under Advancing Health Literacy Franklin County is funded by the Office of Minority Health with the Department of Health and Human Services. It's part of a $3.9 million grant. And so we just want to take a second to acknowledge them and thank them for giving us the opportunity to do this work. So we can go to the next slide. Well, we'll stay at that slide. So sorry. But if we go back one slide. All right, I'll get it together. So in a second, I think we're going to talk about the process to building a health literate community. Before doing so, we just want to take another second and acknowledge the team working as Advancing Health Literacy Franklin County, made up of myself and my colleagues here at Franklin County Public Health, Dr. Abrams and her colleagues at Nationwide Children's Hospital, Dr. Crezia Melendez and her colleagues at Columbus Public Health, and then also Dr. Tatine Centel and Kara and a few of their colleagues at the University of Hawaii. And it's important to note that our dynamic team brings together professionals from all of these organizations. And you're going to hear from the 4 of us today, but there are also about 30 individuals from across these organizations supporting our work directly. And I think indirectly, we at times have more support. So we can move to the next slide. All right, so before we jump into this slide, I just want to talk about, it's important to clarify that, and I believe Tatine did it earlier, but we really, in our project, are focused on increasing organizational health literacy. We know individual health literacy is important, but we want to take the onus off of the individual because we also know that putting the burden on them can ultimately lead to poorer outcomes, and that's just not something we want to do. A little bit about Franklin County. All of our team is based here in Franklin County, except our partners over there in Hawaii. And today I am feeling a little jealous. But Franklin County is home to Columbus, Ohio. It's the largest county here in Ohio. Well, it's the most populous, not the largest. We've got a population of just over 1.3 million. It continues to grow. Probably in the next 3 decades, we're looking to grow by about 1 million. And so we have a large county. And with that growth, there's going to be increased demand for language access services, healthcare, and other social supports. And in addition to our large size, we've also been home to a large group of immigrant and refugee populations for many years. The census tells us about 11% of a population is foreign born, and about 13.8% of our residents that are 5 and older speak another language other than English at home. So looking at these 2 maps, you may notice that they have something in common. We have an inverted T in both maps. One is in blue and one is in red. The inverted T in blue represents the CDC's Social Vulnerability Index. And those are the dark blue inverted T is social vulnerability indexes of greater than 75. The map on the right is a health literacy map. Again, that same kind of inverted T in red. And that map represents census tracts in our county that are at risk for low health literacy. So you can see that there's a lot in common. And so our team has decided to focus our efforts on communities within this T. There are 90 census tracts having a social vulnerability of 75 or higher. And within these 90 census tracts, we have about 24% of residents who are Black or African American and about 6% who are Hispanic or Latino. So we can go to the next slide. So we all know certain factors increase the risk for low health literacy. It's true for our project as well. The 90 census tracts that we just talked about have a higher vulnerability for disparities, generally and specifically for racial and ethnic minorities residing in the community. And some of those disparities include higher confirmed COVID cases and deaths, higher social vulnerability index, and those 90 census tracts that average is about 87. We have a higher uninsured population in this area, higher population of folks with limited English proficiency, and also higher populations with no high school diploma. And lastly, lower COVID vaccination uptake. And so talking for just a moment about our grant, we'll talk about our goals in a second. Our main goal was to reduce COVID-related health disparities, but we also recognize that this health disparities aren't limited to COVID. And so as we start talking about our plans and our goals, it's important to note that we really did want a sustainable plan that goes beyond COVID. So next slide. So in addition to reaching individuals with high social vulnerability index and census tracts, reaching new Americans who often have limited English proficiency is also a focus of our project. Within the racial and ethnic minority population of Franklin County, about 14% of residents are new Americans. That includes the largest U.S. population of Bhutanese, Nepalis, and also the second largest population identifying as Somali. Franklin County is also home to many Ethiopian, Eritrean, Congolese, Burmese, and Hispanic populations who represent many other cultures and speak many languages. So in addition to our disparate population described earlier, we're also focusing on East African New Americans because we have strong existing contacts within community groups that serve these populations. So next slide. All right, so here we are to our goals. How are we building organizational health literacy in Franklin County and decreasing disparities faced by certain populations in our county? Well, by making progress towards our goals. And so goal 1, you can see to create an array of community and health informed COVID messaging and modalities across the county. And goal 2, create a sustainable Franklin County community organizational health literacy model. So when we talk about this, a lot of times I think we tend to say goal 1 is mostly associated with year 1 and goal 2 is more associated with year 2. There's been quite a bit of planning. We've moved in mostly, we're still working towards goal 1, but goal 2, I think was well underway at this point. So we can move to the next slide here. We'll talk about goal 1 a little bit, and to help in addressing this misinformation and vaccine hesitancy through training, communication, and message creators, we've partnered with several organizations. And I think that if there's one theme throughout the work we're doing, it's partnership and community development and capacity building. And so one thing we've done is we've brought a series of trainings to our community. The first one, we partnered with Health Literacy Connections to bring reader-friendly plain language material workshops to the community. It's a series of trainings led by Dr. Audrey Riffenberg, and they specialize in helping healthcare professionals and systems, public health professionals, researchers, nonprofit and government agencies to adapt their organizations so their audiences can more easily understand and use the information in services. So really working with community organizations and message creators to make sure messaging is friendly and understandable so that our community members can use the information to best inform improving their health. We've worked with Communicate Health to offer a digital health literacy training series that they tailored for us. They focus on things like user testing, numeracy, data visualization, visual design, designing for accessibility, alternate text, and more, and really just focus on best practices to create clear health materials for all users. We also have partners at ETSS, Ethiopian Tewahedo Social Services, which I mentioned earlier as a strong connection between our work and the community we're serving. They're an organization that helps new Americans from all countries establish roots and gain self-sufficiency here in Central Ohio. And they've provided a cultural competency and class training that aims to define cultural competency, enhance the understanding of the diversity of our area. They focus on the distinct needs of various ethnicities. They provide insights into solutions from the perspectives of members of the various cultures in the community. And these navigators from these cultures, they share and they present what they want people to know about them and their cultures, their communities, and their needs. And this has been just so well received and so wonderful. And we are just so glad that we have them helping with this. Let's see. And lastly, with message testing, we've partnered with Cohere, and they're a grassroots and community-focused market research firm. They held focus groups throughout the community to gain knowledge and insights on residents in those high social vulnerability index areas in the county. And they've helped to provide solutions for advancing health literacy with a focus on COVID-19 education and engagement. And then in terms of identifying existing or new partners for integrating health literacy informed strategies into COVID-related messaging, we've convened a partner advisory committee here at Franklin County Public Health. And we've also partnered with, again, our partners at Columbus Public Health to incorporate the work they're doing with their health literacy committee. And so some of our partners involve or include community-based organizations, federally qualified healthcare centers, and they've been a great asset to help with guiding our work and just giving us feedback, making sure we're not missing important points, making sure we have the right people at the table. And lastly, one other way we're bringing in new community members and new partners is through the Health Literacy Learning Collaborative. And I'm not going to spend too much time talking about that because I believe Dr. Abrams will speak to that. But this is a wonderful initiative led by Nationwide Children's Hospital. It's a short-term learning system that brings together different organizations from the county. So whether it be healthcare systems, nonprofit organizations, community-based organizations, I believe we have folks from our Justice Center involved, and really just helping, letting organizations lean on each other and hear from experts in terms of what they can do to help build their organizational health literacy. So next slide. So for goal 2, to create the sustainable plan, we have a couple objectives underneath. And the first one is to identify at least 5 health literacy champions and training teams within the community. Happy to say we currently have at least 10 health literacy champions, and they continue to grow. Champions are key personnel who advocate and promote the health literacy training initiative, and each current champion participates in this reader-friendly plain language materials workshop series, patient education materials assessment tool, and the CDC Clear Communication Index assessment. They're trained on that, and they use that to help us assess materials. They help community organizations assess materials when needed. And then they keep their skills sharp with ongoing material review. They go through teach back training. They also experience the culturally and linguistically appropriate services training, digital health literacy training, and a health literacy overview training. Champions also complete the Institute for Healthcare Advancement Health Literacy Specialist Certificate. And this training model equips champions the knowledge and the fortitude of confidence to go out and provide training to organizations in the community. Something really exciting that our champions do is they offer 3 training presentations to the community. They offer a 90-minute public health focused presentation, a 90-minute clinically focused presentation, and a 3-hour in-depth clinically focused presentation. The 90-minute presentations provide an overview of health literacy and cover topics like individual and organizational health literacy, plain language, teach back, and reader-friendly materials principles, the importance of health literacy and equitable, safe, high-quality patient and client-centered care and services, and then also using health literacy informed strategies in their setting to advance as a health literate healthcare organization. The 3-hour presentation for clinical audiences also provides an in-depth content on the same topics covered during the 90-minute presentations. So we can move on. So again, for our health literacy champions, they all go through the same training. Everyone in every community-wide health literacy champion attends the same training. I will say that the models used to select the champions at different organizations varies, but the expectations are the same, that they will attain the core health literacy and organizational health literacy knowledge and skills, that they collaborate internally and externally to foster development of healthcare organizations, that they deliver these trainings that we just talked about to the community. We ask them to participate in various projects as we move through the work. And then we also ask them to apply health literacy principles related to COVID and other disparities. I briefly want to say we couldn't do the work we do without our wonderful team, but without our amazing champions. And our champions range from physicians and nurse practitioners. We have I believe a physical therapist. We have health educators. We have public health program managers. We have program managers within nonprofits that work with us. So the spectrum of folks who are serving as champions is there's a variety, but again, they all do the same wonderful work. So next slide. Okay, so also with goal 2, we are developing a project website with resources and a tiered training menu. And I'm very excited to say that we launched this website about 2 weeks ago. So we were on time for Health Literacy Month, which is exciting. The goal with this website is soon to have it available in more than 13 languages. We did launch it to get our tiered training menu out, but we're still making a few changes. But to recap, the website houses several different resources. So individual training options like the IHA's Health Literacy Specialist Certificate. There's a request form listed on our website where folks can go and request that. There's a request option for our 90-minute and 3-hour trainings. We have it's small right now, but it's growing, a library of recorded trainings that will be available in the future. And we have plans to add the Building Health Literate Organizations, a guidebook to achieving organizational change, the second edition once that's complete. The nice thing about this website is that resources are going to continue to be available for future community use to sustain the increase of organizational health literacy once the grant period ends. So next slide. And so as part of goal 2, as well, we are working to identify and recruit organizations and individuals for participation. And as we do this work, We're connecting with local school systems, universities, hospital systems, federally qualified health centers, managed care providers, community-based organizations, and others. And we're offering various levels of engagement in the project. So as you can see here, for capacity building, we have a tiered training menu available for folks and organizations interested in advancing as a health literate healthcare organization. And that is a lot to say, no matter how many times I say it. We also are and welcome folks. Our health literacy learning collaborative kicked off in October, but we welcome other organizations to join us to assess their organizational health literacy through the Enliven tool. And also we welcome organizations to have staff members complete the health literacy specialist certificate. And lastly, if folks are interested in partnering, if they want to, if they have the time to commit, we welcome them to join our Health Literacy Partner Advisory Committee, which again serves as a steering committee to help us guide our work. We come to them with ideas and get feedback. We ask them to make sure, again, no one's missing from the table. What have we missed? Are there ideas that we aren't thinking of? Are there folks we haven't included? We really do want to be as inclusive as possible. And then the other thing is folks can engage with the Columbus Health Literacy Committee, which I believe they meet monthly, and every month they have a presentation and also an opportunity to develop health literacy skills. So next slide. So at FCPH, we want to be sure we're leading our communities in achieving optimal health for all. And along with our partners at Columbus Public Health, we know that not everyone has the same opportunity to be healthy. Obviously, achieving organizational health literacy is valuable for equitable public health programming and for building health within our communities. So as we work to build organizational health literacy, it really helps us in preventing health problems, protecting the health of our communities, and better managing the problems when they arise. Reducing inefficiencies, building better patient-provider relationships, and empowering patients and their families will result in a reduction of not only COVID-related, but also other health disparities among socially vulnerable individuals in high-risk communities. Next slide. So we're doing all this work. And how do we assess organizational health literacy? Well, on our end, we're constantly evaluating our efforts and always working to improve. We have a wonderful team at the University of Hawaii who leads our evaluation efforts. And so, you know, how do we know we're increasing organizational health literacy? Well, to start with, our core organizations here at Advancing Health Literacy Franklin County, we've all completed an Enliven organizational health literacy assessment where we scored our own organizations on our progress towards achieving the 10 attributes of a health literate healthcare organization. And I know Dr. Abrams is going to talk more about this, and so I don't want to go too deep into it, but I do want to say that it's been a really exciting process, and we are just so excited about supporting some of our partner organizations as they do the same. So that was a little bit about evaluation. A very little bit. Also, you know, I think we know we're doing good work when we talk about some of our successes. And so in closing, I just want to share a few exciting improvements that we've seen over the past several months here in Franklin County. Again, Columbus Public Health is working with their Office of Planning and Quality Improvement to improve the signage throughout their building. And then also they developed a health department-wide policy on reader-friendly materials and message testing. Nationwide Children's Hospital is doing so much, and they're collaborating with their other internal health literacy related quality and research projects that address social determinants of health, and collaboration continues with their internal team. I did not ask you to advance the slide, did I? Oh my gosh. Okay, well, it must be missing. So, but really at NCH, they're doing everything they can to broaden their overall health literacy related activities. And here at FCPH, we've been incorporating system-wide changes to our plain language review for any sort of communications request that comes through. We've also added a class training component for all employees. And lastly, as a result of one of the cultural competency and class trainings offered by our partners at ETSS, a local school system added vegan menu options for students and staff to honor dietary restrictions throughout the year. So last slide is our, I think, tagline at this point. Thank you. And what questions do you have?
Awesome. Thank you very much, Heather. That was a great overview of the project, and you can see really all the intricate parts and the nuts and bolts. I can see some questions coming in for a robust discussion, but also know we only have a finite amount of time. And so we'll go on and turn it over to Marianne to do her portion of the presentation and just keep that cracking and moving along. But can we all give Heather, just in our own little Zoom bubbles, a round of applause for her wonderful presentation. And we'll turn it over to Marianne to talk about the organizational health literacy perspectives. And just a plug, thank you, Cindy, for the great questions. And please keep them coming in so we can have our robust discussion at the end. Thank you.
Okay, great. Thank you. Can someone give me on our panel, give me a thumbs up if the slides show up okay? Thank you to team. Great. So this is part 3, I guess part 2A, 2B. I really appreciate the opportunity, like everyone else on the panel, to be able to share this and to learn from all of you in the audience, the listening audience today, and see what we learned together. I'm really grateful to be able to be working with such great team colleagues. And also I want to give a shout out to Gail Nielsen, a colleague who's a specialist in organizational change, who also is contributing to our work. So thank you for joining us. And you'll see some of these slides or wording. And we sort of did a bit of a thoughtful discussion about, is this too much? But we really do want to emphasize some of these points. So we won't dwell on them, but we're trying to weave this story together. And hopefully I can, there we go. So you've heard Heather, Tatine and Heather both talk about our 2 grant goals. And Heather gave a really nice overview. I'm going to be focusing primarily on goal 2. And the operative words here are sort of in bold. We really, really, really want this to be sustained after June 30th of 2023, which is the conclusion of this 2-year grant. So we really want some sort of a sustainable infrastructure to be achieved through capacity building, and also to enable what we accomplish and learn through this. Yes, to reduce COVID disparities, which is sort of the way the grant was originally structured, but also to be able to use this to address other health disparities and promote health equity. And this isn't news to anyone probably on this call, but I think it's always nice, especially in the organizational level. I loved the socioeconomic, socio-ecologic model that Tatine shared. This part of this is that intersection between the product of individuals' capacities and the demands that we put on people when they work or come to us or we reach out to them. And the fact that we're excited because something I think many of us in the field have been working for at least a decade probably, is talking about improving the skills of the system as we communicate with individuals, whether they're employees, patients, families, clients, community members, or our own staff. So that's the intersection that a lot of this part of the work is focused on. And I think we really need to recognize how valuable it is that Healthy People 2030 explicitly elevated health literacy. Cindy Brock has shared this information a lot with folks, but the points are really important because they included health literacy in the overarching goals and foundational principles of all the Healthy People 2030 objectives. And they actually established this organizational health literacy definition, which now gives us something concrete to talk about and tether from. And as we know, the Healthy People objectives and documents help guide and influence policy and research and funding and all the things that drive evolution in our healthcare system. So we've already talked about the original definition of personal health literacy and the combination with this new definition of organizational health literacy that together constitute health literacy writ large. And we really emphasize this concept of the organizations who equitably enable individuals to carry out what they need to do to care for themselves and their family. And the other really important emphasis that Healthy People 23rd made is that achieving health and well-being requires eliminating disparities, achieving equity, and attaining health literacy. So you have to address health literacy in order to accomplish those things. And that helps us to explicitly state that the health system has the responsibility to provide clear, understandable information and make sure that it's understood by those who need that information. Not just say, oh, we have these great materials that are written at a certain level of reading, but to know how to communicate. And at the end of the day, to circle back and make sure people really understand. I'm not going to go through this in depth, but hopefully everyone is familiar with the 10 attributes of a health literate healthcare organization that are pretty well rounded. And all of these are important. Leadership, support, and buy-in, integrating it into planning, evaluation, quality, safety, training the workforce, including consumers, users, patients, families, clients, up front, not just at the end when we're rolling something out and say, don't you think this is great? Looking at the care environment, working really, really hard on our interpersonal communication and making sure that people understand, access, navigation, easy to read materials in all formats, really focusing on high-risk points and communicating cost information clearly. So why did I go through these? Partly because I think they're pretty comprehensive, and partly because I think they provide a really good framework when we're talking to people and community and organizations of a whole variety about health literacy. Because as a lot of people think of health literacy as just language access or easy to read materials, but it's a very comprehensive body of work. And it's not that you can achieve all these at once, but they do represent the comprehensive approach. And the other word that we've started using, is health literate health organizations, because we are being, as Heather pointed out, very inclusive of non-clinical entities that are very impactful and important for promoting health. So public health, community-based organizations, and others. So the framework that we're using for our work, for the trainings and educations and ongoing progress, is the 10 attributes. And we've chosen the Enliven as sort of our assessment tool because it maps well to the 10 attributes. It's not a perfect tool, but it seems to map well for this framework that we've chosen. And it's flexible and adaptable enough that different organizations can use it and see how it works for their particular experience and their focus of their work and their mission. So you've heard plenty about the name of our about our grant and the name, and we really are looking at building a health literate community based on this equitable approach in response to COVID. So another piece that we're really trying to emphasize, again, not just health care delivery, but health literacy matters in all health settings. And whatever end of some of these things you're on, if accreditation regulation certainly matters at Nationwide Children's Hospital, but it also matters to the people that come out and do that accrediting and regulation and inspection. Clearly, risk management issues affect all kinds of organizations, whether it's clinical, public health, et cetera. Equity, we all know that is pervasively important. And training and education are vital. That's how we make changes, but it's not the only way that it's not sufficient, necessary, but not sufficient. And then different things are going to be important to quality, patient satisfaction, patient safety, patient experience. And I'm sure we could put a whole lot of more, what are these hexagons? We could fill up this whole screen, but this sort of tries to hit all of those key areas, regardless of whether it's a clinical or a non-clinical entity. And we have to accept the fact that the business case is important, and that may take the form of incentives, indirect and direct costs. We know it's challenging to measure that, but it really encouraging people who are joining us in this to think that through, to help make that case when they're trying to engage leadership and make the case for the different components of the attributes is important and vital. So you've heard Heather outline a lot of the activities that we're doing through the grant. And the health literacy champions are very important, not just because we want to have a dozen people that are really knowledgeable. We identified the champions within our core team, grant team organizations. And now what we're trying to do is to build champions within our partner groups, partner organizations, so that they too have these embedded folks who are going to take it to the next level, to be the institutional memory, the institutional driver, so that if somebody leaves or retires or whatever, there's still that ongoing capacity. So the champion model is really important. And then the training, we spent a lot of year one ramping up, so to speak. We've created this tiered training. We've tailored it a little bit for clinical and non-clinical or public health audiences. We've provided a more in-depth one if folks want a more in-depth one, and added these other added value trainings that Heather described in really valuable, or really excellent detail. Again, the reader-friendly workshops and the IHA Health Literacy Certificate are also much more in-depth, and other ways to help build these health literacy champions or these health literacy teams within organizations to leverage that and help sustain that progress. Talked about the Enliven organizational self-assessments. I'll talk about that in just a little bit more in the context of the Health Literacy Learning Collaborative. What we were learning as we started to do our own self-assessments, and then because we want to look at the Enlivens at the beginning and then toward the end of the grant and periodically throughout, if as we are able, you can fill that out, but then you have to do something with the findings, right? So our core grant team is working on that, but then we really wanted to recruit these other organizations, and we've gotten several. And what we learned was to help provide that support is relatively inefficient if you're trying to do it for one organization or one group at a time. And so that's why we decided to go ahead and move forward with the learning collaborative model for year two, to really broadly invite a host of organizations that all of us interact with to this 6 to 7 month accelerated learning opportunity to really make progress on becoming health literate health organizations. And we launched that October, goodness, just a week ago today, huh? And it was very exciting, and I'll tell you just a little bit more about it. But this way, all of those groups also completed an Enliven. So we went from having 4 to 5 of these to now we have at least a dozen Enlivens. And I'll tell you a little bit more about it in just a second. The other piece, again, Heather touched on this. At the end of the grant, we want to leave these enduring supports. And she talked about the website, which is launched this week or last week, and will really help become sort of the home for all things health literacy related for Franklin County, but also links and connections outside of our area. And many of you are probably familiar with the Building Health Literate Organization Guidebook for Organizational Change. Through the grant, we are able to develop a second edition of that, which we hope to have finalized at the beginning of 2023. And in addition to updates, we're also incorporating a lot more content that has evolved in the decades since that was originally written, including a major focus on the intersection between health equity and health literacy. We're also updating the Always Use Teach Back toolkit to include, again, not just update, but more equity, culture, language, some of the data, and updating some of the tools and getting some great input from key informants and users to inform that work. So again, we want to leave these things, I don't want to say leave behind, but leave these things as part of the capacity building and infrastructure. And this is just a visual to show we have 14 teams who are part of the Health Literacy Learning Collaborative. And these run the gamut from a payer who pays, covers a large part of our Medicaid population, several different clinical groups from major hospital systems in Central Ohio, including the Ohio State University Wexner Cancer, James Cancer Institute, a couple federally qualified health centers, the public health groups, associations that focus on the populations and providers to promote the health of Asian Americans and Asian Pacific Islanders. A couple of the clinical teams are very much focused on community benefit. So there's a really nice interface there with social determinants of health, health equity, and language access. Also, a couple other, the Ohio Justice Policy Group, and a food justice and food access organization. So you can see the diversity of these organizations. And it was very impressive, again, a week ago to, the first session was pretty much, helping give them the knowledge and the data and what they need to make the case and pull teams together at their organizations, and to to develop them into health literacy champions, and the excitement of them talking to each other and crossing teams over already. Some really creative ideas were already emerging from that. And the other nice thing about the collaborative model is some larger, I guess it should have been self-evident, but it became evident that a large organization it's going to be almost impossible to do a major self-assessment. So we're encouraging a lot of these groups to do a focused assessment. So our quality and safety team is going to do a focused Enliven in that domain. Our equity team is doing that. Our home visiting team is doing that, and other groups are as well. And some are going to repeat theirs now that they're digging deeper into the work. So this will wind up in April. We'll have at least a dozen organizations with their plans. We'll have developed additional champions and people that are learning from and sharing their obstacles, but also their solutions to some of the things that stand in the way of making progress with organizational health literacy. We are taking the approach that we need to use a QI approach, and being a strategic, learning from making small changes and having lots of conversations. That's why we're kind of making some of these adjustments mid-course as we move through the grant. I think Heather described those, and I've elaborated on those. Encouraging people to use small tests of change, start with a very small test. We challenged all our collaborative partner organizations to come back to do one test before Halloween and to start ramping up. And then hopefully they'll be able to test different interventions in multiple areas. We have emphasized over and over and over again that you don't go into your office, close the door, and come out with a plan. You have to build relationships with your volunteer team. You have to lay the groundwork. You have to be willing to try new things and learn from things that don't go well, and to work collaboratively with your colleagues, partners, stakeholders, clients, patients, and families. And the reality is multiple attempts are often needed. You do have to try different approaches. And to remember, I think Thomas Edison also highlighted this, you learn more when something doesn't work than when you hit it out of the park on the first try. Again, we're moving toward a reliability, making sure that we use teach back every time it's indicated, and sustainable, that it doesn't deteriorate when the champion leaves or change jobs or moves to another department. Regardless of who's participating, it's sustainable. We've equipped people with these matrix of change ideas, things that are easy and harder to implement, and how much you think it may help to make improvement. And kind of tossed out the idea of maybe putting the attributes of this matrix and then moving them around to see which 2 or 3 you might want to begin your work with. So we know we have this great array of health literacy practices. We got universal communications precautions, class standards, all plain language and teach back, reader-friendly materials and accessibility. We are challenging everyone to figure out how to deploy these in a reliable, sustainable fashion. They need to think about how to align this with their mission and integrate it into work they're already doing. It's not supposed to be one more thing, one more silo, one more project, but how do we build it into our equity efforts, our quality and safety work, our faculty and teaching roles and role modeling, evaluation? How does it look on our performance scorecards, and how does it look with our community engagement? And then you can work on policies, but just putting out a policy does not achieve success. And don't forget to celebrate the wins. And think about, after you've done all these things, how do you make it stick? How do you incorporate it into just job descriptions, performance reviews, credentialing and orientation? Obviously, training and education are important, but not sufficient. Look at competencies and care processes. How does the electronic record help with order sets, workflow, prompts and checklists, documentation and data that you can use for QI and projects, and giving people feedback and evaluation on how they're using health literacy practices. And don't forget, you got to keep an eye on it down the road. Just a few ideas of how it can be useful. There's checklist examples, teach back prompts and documentation, including it in clinical competencies, training and education, and ultimately making sure it's part of our equitable work. So at the end of the day, as everybody knows when and how to access and work with interpreters, how to stop the line if they sense somebody doesn't understand, and that the reason we came to work every day is we've made sure people understand what they need to do, not just, well, I saw that patient, but I need to make sure they know what they need to do. It's all about the people we work with, the people we serve, the people who are the center of all this work. And with that, I am going to turn it over to Kara.
Awesome. Thank you, Marianne. That was a great informative presentation related to all the nuts and bolts, also of the background, and also other aspects related to sustainability. So everyone, please give Marianne a round of applause. I could see a lot of questions coming in that are going to be amazing for the discussion. Thank you, Cindy, for adding so many nice resources as we go through. We did not plant you there to do that, but we really appreciate your engagement and support. So thank you. So I'll turn it over to Kara, who's going to give a brief overview of the incredible array of the evaluation tools we've been using. And then we will be ready for discussion with the questions. So Kara, I'll turn it over to you.
Okay, great. Can you guys see my slides? Okay, perfect. So like I said, my name is Kara Saiki. I'm from the University of Hawaii at Manoa, Office of Public Health Studies, and the Thompson School of Social Work and Public Health. And so today I'll just walk you through the different interventions, trainings, and highlight lessons learned from the evaluation perspective. So let me make sure I can advance my slides. There we go. So as you know, a few of the panelists have already mentioned, we've had a variety of health literacy interventions that are implemented. There weren't just one of each type. There were many different ones per each type of training. And then we matched pre and post surveys to assess knowledge and our confidence before and after each training. So let me just move on. we surveyed participants about their key demographics, and out of the 61 participants who completed the demographic survey, the majority or 56% were between the 25 to 44 year age range. The overwhelming majority were 84% were women, and 97% reported being Hispanic, Latino, Latina, or Spanish origin. And 66% reported being white, with the next biggest group being Black or African American at 31%. And then finally, the participants who filled out the survey have lived in Franklin County for an average of 15 years. So I just wanted to give you some highlights from highlight two of the trainings that were done or surveys. And so one of them were the Health Literacy Champion Self-Assessment. And so champions for the project were identified and asked to do quarterly self-assessments to measure their familiarity to health literacy, to their self-efficacy, to using these types of skills and demonstrate understanding, and then their ability to engage their organization in health literacy. So for this first one, you can see on a scale of 1 to 10, how familiar are you with health literacy? Kind of across the board, there were some increases from pre to post. And then in this other question, on a scale of 1 to 10, how confident are you in your ability to teach health literacy knowledge and skills? The majority showed increases in their percent change between quarterly assessments. And then about their ability to engage their organization in health literacy best practices, there were some increases across the board, with like 2 showing some pretty substantial changes. So at each assessment, the top 3 teach back skills were reported, and from their baseline self-assessment to their follow-up self-assessment, they reported using a caring tone of voice and attitude, plain language, using plain language, and then displaying comfortable body language, making appropriate eye contact, and sitting down. So these are the top 3 teach back skills they reported using recently. And then, so the other training that I'd like to highlight is the reader-friendly plain language training, which had 4 sessions each, and the average pre-test score was 52%. And after the training, the average post-test score increased to 81%. So the percentage change between the average pre-test and the post-test score was a 56% increase. And so from our perspective, the project objective was to increase knowledge by 50% by June 2022. And so we saw that as being a success. And so now I kind of wanted to dive right into insights and lessons learned. And so the first one that we thought of was the importance of buy-in. And this is from the organization, leadership, making sure that people want this in their organization, and they're willing to let their staff get trained on this, and they believe in it. Another thing that we wanted to highlight was the quality improvement approach. And I know our other panelists have kind of mentioned this as well. The importance of this, how it's an iterative process, like putting in trainings into their contracts, building trust and incorporating feedback, remembering why we're doing this. And so other ways we've used this quality improvement approach is we've been discussing like certain assessments, for example, like the cultural competency trainings and the digital health trainings, and seeing that in general, there were increases in knowledge from pre to post. Therefore, after discussing with our team, as a group, we wanted to keep moving forward while staying efficient and practical. So we knew that the trainings were working, so we could shorten the assessment and relieve some of that burden, the survey fatigue that a lot of people are feeling, and streamline these assessments to 2 questions. So another lesson was thinking about, like, we're working with the same group of partners. And because of that, there might be fatigue, there could be capacity issues, competing priorities. And fatigue was in many different ways. There was Zoom fatigue, there's survey fatigue. And then so to really acknowledge that and celebrate our champions and honoring their needs. Other lessons we learned were the methods and delivering trainings evolved. So it went from free Zoom accounts and it shifted to 45 minutes. Microsoft Teams wasn't exactly user friendly, so finding other platforms that worked. There was enthusiasm for training and activities, and this enthusiasm was high, but getting people to show up is challenging. So for example, with social network analysis that we've mentioned, like the partners want to know how all the organizations are engaging with each other, but it's challenging to get people to show up, to fill out another survey. So taking extra time out of their, asking them to take out extra time out of their already busy schedules. So we just wanted to think about ways to engage folks, whether that meant sending out like a personal email versus a mass mailing, using our own personal contacts and leveraging our own personal or professional relationships to encourage them to open up that email and see that the survey really does only take 5 minutes. Some challenges that we found were that it is more challenging to become a health literate healthcare organization in a larger organization versus a smaller one. And this is like speaks to that Enliven survey that we've been mentioning, the self-assessment. So distributing Enlivens to different departments and, letting different divisions kind of share their different priorities and understanding what their goals are and their challenges in different divisions or between different divisions to assess their ability to become a health literate organization. So with all that being said, it may look like we're only reaching small numbers when we're talking about the different trainings, but we're trying to build capacity within organizations. Change takes time. And it's important to remember that this is not a sprint, it's a marathon. And so with all of that, beyond the lessons learned from working with external partners, we had to look at our own internal insights and lessons learned. Like we understand the value of health literacy, but does everyone in our organization, and how to get our own organizations on a path to becoming a health literate organization, which meant navigating barriers, gaining internal buy-in, go to where the organization is already focusing and apply it there. And so maintaining our own capacity to do this work is also a big lesson that we learned. Hiring and contracts take a while, as you all know, and all of this adds to the challenges of a 2-year project. So some of our next steps that I wanted to focus on is just comparing the results of the social network analysis at the end of this project. So we're not that far yet into it, but we're hoping to get that at the end. So did our network grow and are more organizations engaged? Are more organizations making improvements on the Enliven self-assessment resource? So as Dr. Abrams mentioned, we're having, with the Learning Collaborative, we have a bunch of folks that have been taking that self-assessment on behalf of their organization. And then how do these target populations feel? Providers share information with them. So we're going to be talking to folks within the FQHCs to see how their providers communicate with them. Is the reach of this project extending into communities with that high vulnerability index that Heather mentioned, particularly with new Americans? And just to remind you that 14% of the residents in Franklin County are part of that new Americans group, including the largest US population of Bhutanese Nepalis, as well as they're also home to Somalis, Ethiopians, Eritreans, Congolese, Burmese, and Hispanic populations. It's quite a diverse population. And then how to share any of these results out. And so I know I kind of sped through all that, but these are my final thoughts. What do all these trainings mean for the big picture? From building up champions to take their newfound knowledge back to their organization, to building up different divisions within larger organizations, to helping organizations think about ways to become a health literate organization, all while emphasizing the importance of cultural competency and the skills needed to make health understandable for all the people that they serve. So it's easy to get lost in all these trainings. So we just want to make sure to continue to discuss with our team what our goals are. And is this information and skills being taught? Are they being used by those providing health information to make an impact on the population's health and their health decisions? And remembering to keep this in the front of our minds in all we do. So thank you so much for your time. And do you have any?
Awesome. Thank you, Kara. Thank you for that overview. Everyone can give a round of applause to Kara as well. And so I know we wanted to save time for a robust discussion, and it looks like I'm frozen a little bit on my screen. But anyway, since I'm on my phone, we're going to have like a whole experience together as I go into the chats up here. But I saw a lot of great practical nuts and bolts questions, which is what we were really hoping for. So the first question I have, I thought was really important from the sharing of the OMH materials, which is off here, but Marianne or Heather, can you guys say anything, because you guys are on most of those OMH calls, the resources that are being developed across these many projects, is there a sense that they are being shared and can be shared with each other and with other organizations?
I will respond and then Heather chime in, and I did try to answer it in the Q&A. I don't know if it went through or somewhere. OMH does hold calls between the different grantees where we do share, and some make presentations and we learn from each other there. And that's led to a couple selected things that we've been able to share or borrow or use or adapt. And we are doing a little bit of collaborative work with the San Antonio project that's also doing a collaborative model and sharing some of those resources. I have to believe that OMH, and we are strongly encouraged by our project officer to share our learning. I am not aware of a specific place where different resources will be shared, but that might be in the offing, and we could certainly pass it along. Heather, I don't know if you have thoughts about that or want to add anything.
Yeah, no, I think that's a great idea to have a location to hold stuff. I think that our projects are, we do all talk, we talk monthly, we have meetings together. I think our projects sometimes are so vastly different that we connect with each other when we say, oh, that's a really great tool, we could use that. And so there has been some of that information sharing, but I really do like the idea of having some sort of portal. So we'll bring that up. Thank you so much.
Awesome. And then another practical question, which I think is true and related to a different question that's about sort of capacity generally and making time for people, is how do we handle staff turnover and what does that look like? Which I know we could talk about for a while, but any quick comments on the staff turnover and how to make sure institutionalized knowledge isn't lost, especially in such a quick project?
You want me to
maybe
go ahead,
Heather,
Marianne?
Or Heather go first and then I'll chime in. We'll
Yeah,
walk back and forth.
You know, obviously, you can see there's a lot of information. We have a lot of things going on. And so I think the thing is on our team specifically at Franklin County Public Health, everybody has a backup. We have a plan. And even today, you know, we had some technical difficulties, but we made sure everyone has the slides. And so I think that just really working together and making sure that we're looping each other in, you know, even when it may not be necessary in the moment, so that everybody is included in the work and everybody has a part and everyone has a backup. So on our end, that's what I can say. We actually have experienced staff turnover. This has been such a great project. We had someone that was recruited to do other work and they took the opportunity. I'm so excited for them. And so, you know, at that point, it was my turn to fill in. And so because the team is so great at keeping everyone informed, I was able to do that. So, Marianne, go ahead.
Yeah, I'll add, I loved Heather's definition of health literacy champion. We hadn't actually formally written that down anywhere, but the way she described it, I thought was spectacular. And I hope I tried to scribble it down, but I didn't get it all down. But I really like that, because what distinguishes somebody who just went through some trainings from a health literacy champion is that they've gone in depth, they are experts, and they are committed, and they are truly champions. They're not just experts, they're champions. So that part of that role is to champion that in their organization or their area. And we've started already, but we'll continue, especially through the collaborative, those last couple slides that I kind of blew through, and I wish I'd had more time, because I think that's the answer to this. It's like, how do you get this embedded so that it's part of hiring and part of evaluation and part of a job description and an expectation, and that it gets on the performance scorecards and the dashboards. And by some of this work that we're fostering in quality and safety, if we start looking at how was communication related to this event, it becomes part of the culture. And we just have 2 new health equity, health literacy champions, and they actually said out loud, we just think we want this to just be the culture of our organization. So it's culture building. So it's not just training and a project of the month. It's really building it into the culture and thinking about that very thoughtfully, not as an afterthought.
Exactly. I think that is absolutely critical, and critical to some question. Hopefully we'll have a chance to get to also about sort of how we build a tipping point and what that looks like. So keeping going in order, and I know we have some in the chat as well. So have either of our states, and I do not think this is, has your states considered passing laws to require pharmacies to provide medication languages in people's languages? Sort of thinking of the social ecological model and the policies and aspects. I don't know that from Hawaii. Do you guys know from Ohio?
Not that I know of, Heather.
Oh, and I was actually just looking into this maybe within the last week or 2. So I'm so glad you brought this question up. Our Columbus Health Literacy Committee actually did a panel on some with local pharmacists, and that was one of the things they talked about. And gosh, if we had more time in our grant, I'd love to do a pilot with a pharmacy on that. But no, to my knowledge, in Ohio, there is not a law. And in terms of if folks are looking into it, I'll be honest with you, that's not something I'm aware of. So
yeah, perfect. Well, not perfect, but something to consider. And thank you for that informed answer. So the next question is about Teach Back, and I think this is an important one. So this person is working the RNs integrating Teach Back into practice, and they're worried about that feeling that they're testing the family, which is something I think we struggle in considering a lot in health literacy. And so really trying to think about how to better phrase what is happening and how Teach Back is learning about communicating well rather than testing the family. And so then others say, but I can tell when the family doesn't understand or not. So they don't think Teach Back is relevant. Any suggestions of how to promote and engage with Teach Back related to these concerns?
I think that's where you get stories and you get people to try Teach Back once, or you, in a group setting, you ask people to describe a situation where someone appeared like they understood or describes their own personal experience, and that universal precautions approach that anyone could experience limited health literacy depending on the circumstances. The fact that the data, so there's the stories, there's the emotion in your setting, there's the data that show that 90% of US adults aren't able to navigate the US health system successfully, very well. And then it's really focusing on how you ask for Teach Back appropriately. And so the body language, all those things that Kara found that were well executed are very important in setting the tone, but you have to also explicitly talk about the provider taking that responsibility. And there are some nice studies out there that show that when people understand why they're being asked, they appreciate and value having someone ask them to teach back. So it's a combination of data, stories, emotion.
Awesome. And so I know we are out of time. We have no more minutes for our session. We have a few more questions here. Are we allowed to stay in this room to answer those? If I know people should head to the posters also to celebrate the good work. Are we allowed to stay in this room if people want to stay in to ask quick questions? Yes. Okay. Awesome. Wonderful. So maybe we will just continue to answer the questions that I see in the chat. And then head off. Please enjoy the conference. It's a wonderful conference. Please give the panelists a hand for their amazing conversation. Thank you all for your tremendous work. And thank you to the host organizers for this wonderful meeting and opportunity to be together. I really appreciate this opportunity. Awesome. So I did see a question and I just definitely wanted to ask up above the, has anybody does anyone know about the officer? Oh, the medical officer. Oh, good, Marianne, you answered that question already. Yes. Do you have any other additional comments about the health literacy medical officer?
I don't know if Andrea is still on the call or not. She may have had a good one. I saw her, she entered something else in the chat. She's leading spectacular work in Milwaukee and Wisconsin. And
Oh, okay.
I know that she's been doing that steadfastly over time and aligning it with key organizational priorities. And that's Andrea Forrest, and I can't give you her email off the top of my head.
Okay, I see her up above, so. I think that's, any other comments? Oh, we still have a bunch of people in the room. Yeah, any other comments or questions people want to add? Let's see, it looks like there's some more up here. Are any that you guys see in the chat? I'm sorry, trying to catch up on my phone is so tricky. Okay, so we're leaving this one live so we can still chat. Any other questions or comments anyone wants to add? Is anybody available to help and mentor anyone who has an interest in doing this work in their own communities? So one suggestion Michael made was a best practice submission for health literacy and research practice to share some of these results and helping on the mentorship piece. Because I do think that at scale is the challenge, right? Sort of, I mean, Kara showed all those different details of all the trainings. Heather talked about all the nuts and bolts. Marianne talked about all the efforts. And I think actually one of the questions I did want to get to that I saw earlier and now I can't find again was how we build in time for the champions to participate in these efforts and really for anyone to participate in these efforts because they do just take tremendous dedication, time, energy, not only for the work itself and the knowledge and the training, but then from sharing out the knowledge and training and then also to evaluate that work. And so Heather or Marianne, do you guys want to comment on how people are building in time for this from the organizational perspective and individual?
So I think I'm sorry, Marianne, I think we're doing it in different ways. I think that, you know, so at Franklin County Public Health, we have a health literacy champion that is dedicated, 100% of her time is dedicated to this work. And so it's just part of her daily routine. You know, at Columbus Public Health, our partners, they have program managers who have maybe other jobs, and health literacy just is a natural fit. And so they have taken on health literacy and incorporated this work into what they do daily. And I know it's different at Nationwide Children's Hospital. So Marianne, I'll let you speak to that.
Well, the goal is to have the kind of staffing like you have, Heather. But I think that's why it's so important to align it with your organization's mission and key strategic priorities, because everybody in the organization is working on those things, or they're supposed to be. And then the job is to paint the picture of how does that priority affect, how is that priority impacted by health literacy or the lack thereof? And what are the opportunities there? So folding it in and adding it to the array of tools that we use to achieve our priorities and achieve our mission and baking it in is the way to do that. Now, it'd be great to have some specific funding and a position, and ultimately, hopefully that's where that would lead. But aligning with missions, don't let it be a project flavor of the month or a project one and done. It has to be cross-cutting and integrated.
Awesome. And thinking, and so actually Andrea responded in the chat related to the question of the building and the position of the medical director of health literacy and sort of baking that in and baking that into the org chart and what that looks like. So thank you, Andrea, for adding to that.
Thanks, Andrea.
I think Tatine might have gotten cut
Oh.
off.
Oh, that's too bad. We're lost without her. Is there accreditation for health literacy care organizations? I've heard people play with that idea. I think some people talk about you don't have to be certified, but you could say we achieved a certain thing. So I don't see anything wrong with that, but I am not aware of any certification. And even the IHA certificate program is very clear about what it is and what it isn't. She's back, but you're muted. Can't hear you, Tatine.
Oh no, Tatine, we can't hear you. Okay. Okay, well, I'm pretty sure she's trying to say that, we're we're very, very happy that you guys were able to stick with us throughout our presentations. And if you have any other questions for us, you can either throw it in the chat or we can also put in, I guess, our emails into the chat as well. Oh, there, someone did. Thank you very much. Okay, thank you so much, everyone.
Thanks, everyone. Go
Bye.
forth and do great work.
Yes,
Yes.
thank you. Enjoy the rest
And
of this
let us all
wonderful
hear about it.
conference.
Bye-bye.
Okay, thank you. Bye-bye.